Good day, people. We're here to talk about the fourth concept with respect to patient positioning. So we've already talked about concept number one, which is the table makes stable. Okay, so the more contact surface the patient has with the table, the more stable they are, the safer they are. We change their position and we change that level of stability and level of safety for the patient. So we go to the second concept, which we discussed before, as mentioned, is that less stable means I need to make the patient more stable. Okay, how do I do that? Well, that's the third concept. The space between us is unstable, aka we want to remove as much negative space as possible. So now what we're considering is, how do I choose the actual position that I place a patient in to perform treatment or to administer treatment that's most appropriate? Well, we have a basic concept here. It's not as much of a catchphrase as far as the little catchphrase that I'll use. It's a little bit longer. So the basic concept being, I want the anatomy that I'm working with to be exposed, free to move in the plane required, and preferably visible. Why do I want it preferably visible? Well, we're thinking about a concept called multisensory organization or multisensory integration. Okay, so there's lots of information out there, and one of the things that it points to is that if I have a weak stimuli on one sense, such as touch or sight, if I add it to a weak stimuli on another sense, then the total stimulus is higher. So I have greater confidence and greater understanding in the actual phenomena that I'm experiencing. And there are sensory issues, there are sensory tricks we can play on ourselves. So because there are sensory tricks we can play on ourselves, whether with vision or with touch, I would rather have both combined when treating a patient, so that I'm more confident not only in what I'm doing, but also the result for the patient. And I can also have the opportunity to adjust as necessary, change my approach, so it's more suitable for the patient, more to the patient's general outcome, or to improve their general outcome. So again, what we want as far as patient positioning is for the patient to be, or for the anatomy rather, to be exposed, free to move in the plane required, and preferably visible. So here we are talking about the fourth concept with respect to patient positioning with the patient on the table. And this concept, just to recap, is that we want the anatomy we're working with to be exposed, ideally, free to move in the plane required, and preferably visible. Okay, so here we have our patient in prone. We go back to the first concept, that the table makes stable. Okay, so patient's in prone, nice and stable. I can very easily work on all soft tissues on the back of the body. I can work in multiple planes in a less than ideal fashion. So I can work in the coronal plane by lifting the leg and pulling it away from the midline to tip the pelvis onto the lumbar column. I can pull the arm down to work on the in the coronal plane in the thoracic region. I can lift portions of the patient off the table, like one half. I can pull the pelvis towards me to create motion in the transverse plane. I can create extension in the sagittal plane. So these planes are available to me, not perfectly ideal. I could, if I wanted to, also do other things to greater engage the sagittal plane, but we'll speak about that in another video. So what we're going to have the patient do is we're going to have the patient lay on his back, just so that we're complete in this. So now the patient is in supine. I can work on soft tissues on the anterior surface of the body. I can engage the sagittal plane by lifting the leg away from the table to get into the lumbar column. I can, in some instances, lift the patient off the table to engage the sagittal plane in the thoracic, or in the thoracic region. I can work in the coronal plane by pulling on the arm, by pulling the leg away from midline, and work on the neck very well. Okay? What we want to do, again, we're considering that we want the anatomy we're working on to be exposed, free to move in the plane required, and preferably visible, so I can work on the anterior surface of the body very well. I can, in certain circumstances, work on the posterior surface of the body, but again, it's not ideal. So we're going to have the patient sit up, just so you can see this. We don't need to necessarily show this in every position, but we're going to show it in supine, as we did, prone, and now seated. And the same concept applies in lateral. So if I'm thinking about planes, I'm just going to have you tip to the side. Okay? So coronal plane is easily accessed here. Right? The coronal plane is not as easily accessed in lateral recumbent, but we'll talk about that in another video. Have you twist backwards. Okay? Now the transverse plane is available to me. Tuck your chin, roll forward as best you can. Sagittal plane is fairly freely available to me, and we'll talk about the pros and the cons with respect to seated as far as each of these motions. But just to provide some visual example with an actual patient, that I want the anatomy exposed, free to move and preferably visible. So say I'm standing behind the patient, most of the things that I would want to work with in the vertebral column, exposed, free to move in the plane required, and visible to me. Okay. It is a little bit more difficult in a seated position to work on the anterior surface of the body, but it is available. So again, just to recap, what we're showing you is simply visual examples of having anatomy exposed, free to move in the plane required, and preferably visible. It's not necessarily necessary every time. There are times when, say, a patient's in supine, you'll work under their body for some reason, but it's not the most ideal. Say you wanted to work on ribs in supine, well, it may be more advantageous to work on them in lateral or in seated because they're free to move in the plane as required and they're visible.